about development description of a national cohort of greater than 1 million patients with CLTI using Medicare claims, the chronic limb-threatening ischemia process performance cohort, or the CLIPPER cohort. These are my disclosures. So PAD affects 17% of Americans age 65 or older, as we all know, and 5 to 10% of these patients will progress to chronic limb-threatening ischemia. And untreated, about more than 20% of patients with CLTI will progress to major lower extremity amputation within 12 months, and a similar number of patients will die in the same time period. So unlike other common and morbid cardiovascular diseases, like heart attack, like stroke, like heart failure, there are no quality metrics to measure process of care in CLTI. And the reason for this is that it's actually pretty hard to develop the right type of cohort to understand process measures in CLTI. That's because it's an inpatient or outpatient diagnosis that has longitudinal inpatient and outpatient treatment. Patients may or may not ever undergo a procedure, which are easier to track using administrative claims and other data sources. And PAD affects individuals who have less access to care and may go to hospitals that have fewer resources to participate in sort of structured registries. So the ideal CLTI cohort has to use longitudinal inpatient and outpatient data from unselected hospitals and identify patients by diagnosis rather than procedure, which is, I think, a challenging thing to do. But that's what we tried to do. So we used Medicare fee-for-service claims data to identify patients aged 66 to 86 who had diagnosis codes consistent with CLTI and testing for PAD within 6 months before or after documentation of these codes. So diagnosis codes consistent with CLTI were identified by extensive manual review of ICD-9 and ICD-10 codes based on a previously published ICD-9 algorithm validated by ChartView with a kappa statistic of 0.8 indicating excellent agreement. And so these codes can be broadly thought of as being in two buckets. The first one are these CLTI-specific codes, which are things like PAD with rest pain or PAD with osteomyelitis or gangrene. And that was 58% of the patients were identified in that way. And the rest of these patients had a code for PAD plus another code for infection or ulceration during the same encounter. And that was 42% of patients. And so in addition to having these diagnosis codes, we also required that patients had some sort of anatomic testing for PAD within 6 months before or after documentation of these codes. And so they had to have an ABI or a vascular ultrasound, CT angiography, MR angiography, or an invasive angiography. And so we started with about 2 million patients that met our coding criteria. And then we wound up excluding about 870,000 patients who didn't have any arterial testing within 6 months before or after meeting coding criteria. And we wound up with 1.13 million patients between 66 and 86 years old that had a diagnosis of CLTI in Medicare claims. And we have long-term outcomes for these patients. So here are baseline characteristics. As expected, this is an older population. So a mean age of 75, about half of them were women. 77% white, almost 15% black, compared with an overall Medicare population, which is 7% black, so overrepresentation of black patients. 50% had diabetes, 81% hypertension, 26% chronic kidney disease, and 26% congestive heart failure, consistent with what we know about the common comorbidities in this cohort of patients. We were able to use Medicare claims to divide patients into Rutherford classes. With Rutherford 6 having a code for gangrene being approximately 9% of patients, Rutherford 5 with a code for osteomyelitis or ulcer being 41% of patients, and then the remainder, about 50%, being Rutherford 4 and having rest pain. And so these are the long-term outcomes for these patients. And so this shows revascularization in the full cohort. Within 30 days of diagnosis, about 20% of patients underwent either percutaneous or surgical revascularization, and 28% within 6 months. When we looked at this by Rutherford class, you see that patients with higher Rutherford class were more likely to undergo revascularization, as might be expected. This is major amputation, and we see that within the 6 months following diagnosis, 3% of patients underwent major amputation, about 1% in the next 6 months, and then about 0.5 to 1% every year following that. Amputations were concentrated in patients with Rutherford 6 CLTI, with about 20% undergoing amputation within 6 months. And this is mortality, which I think is sobering. So 17% of patients died at 1 year follow-up, 35% at 3-year follow-up, 50% at 5-year follow-up, and 77% at 10-year follow-up. When we divided this by Rutherford class, you see the worst outcomes in patients with higher Rutherford class, again, as expected. So Clipper is a database of 1.13 million patients with CLTI developed through an extensive manual review of ICD-9 and 10 codes. And I think that our cohort demonstrates face validity. Consistent with what we know about patients with CLTI, there's an overrepresentation of Black patients, high rates of key comorbidities, very poor outcomes, and worse outcomes with higher Rutherford class. And this highlights in a national sample the very poor outcomes with CLTI. And when thinking about this, I think that more than just describing this cohort, I think the implications are important. So process metrics have been a key component of quality improvement for myocardial infarction, for stroke, for heart failure, but there are really no process metrics for CLTI. The Clipper database gives us longitudinal inpatient and outpatient data over 10-year follow-up, which facilitates studies examining the association between process measures and outcomes in the overall CLTI cohort, as well as in subgroups, such as by rural versus urban location, race and ethnicity, or high and low socioeconomic status, which we know CLTI affects patients in some of those groups much more severely. And next steps will be looking at the association between various process measures and outcomes in this cohort, things like time from diagnosis to revascularization, the extent to which patients receive subspecialty care, wound care, imaging, revascularization, and things like that. And so this is simultaneously published in SCAI, and the QR code will take you to our paper. Thank you all for listening, and happy to take some questions.
Thank you. So I have a simple question. It's probably a stupid question. Are we tracking, and you probably could in the Medicare claims database, how many of these patients get aggressive risk factor modification treatments? Because the mortality is obviously the lesson here, right?
Yeah, so it's actually somewhat difficult to do to look at aggressive risk factor reduction in Medicare because Part D data is incomplete, and we actually are not really able to track that very well in this cohort, which is going to be a limitation. A number of other cohorts have really suggested. There's a VA cohort that's somewhat old now. There are other registries and selected populations suggest that we're not doing a very good job with risk factor modification, and I think that any effort to improve outcomes in these patients is going to require that.
Any other comments or questions?
Yeah, so I think your discovery about Black population, that's quite interesting. The previous presentation, that's Medicare database, and they're using the revascularization, and the rate was exactly 14%. There is this big push that access to care. So I think it's just what your data represents is that prevalence in Black patients much higher. I think what would be interesting to see when you get the data from diagnosis to intervention in minorities, I think that would be really important to look at, because I think obviously access of care is a big thing, but when we look at these revascularization, especially surgical revascularization offered to Black patients, I think that percentage would be much lower, in my opinion.
Yeah, I presented some of this using actually this database. I presented some data this morning looking at pre-amputation care by socioeconomic status, by race, ethnicity, and by urban versus rural. And what we saw, we looked at people from this database that underwent amputation and what sort of testing they had or treatment they had in the year prior to amputation. And patients, Black patients, rural patients, and low socioeconomic status patients had a lower chance of revascularization in the year prior to amputation. And also, I think just as importantly, lower chances of seeing their primary care doctor, lower chances of seeing a vascular specialist in the year prior to their amputation. So I think that's an example of what data like this can show us in terms of how we're taking care of these patients.
Yeah, congratulations. I think it's a nice resource to have this registry available. It would be interesting to look at, you looked at all-cause mortality. Is it, CV, is it infection? Maybe try and figure out what these people are dying for. Obviously, it's overall a sicker population, so it's not surprising that they die, but what are they dying from?
Yeah, it's a really good question. And, Medicare claims data does include cause of death. I think the question just becomes how accurate that really is. And when somebody dies and they have severe PAD and they may have CAD and they may have congestive heart failure, maybe they die of an infection. It's just, I think, really hard to sort out. It's hard clinically to sort out the cause of death often, and I think it's especially hard in administrative claims data. So we didn't make too much of that, but I think that in a future paper we may look into that.